to this webinar on co-administration of vaccines with a particular emphasis on COVID-19. So our speakers today are Professor Lisa Nissen, who will begin the process, followed by Jean-Marie Okwo, Bele, who will also participate, and then we'll have a discussion led by Kate Russo and Gabriella Cinti. That'll be, I'm really looking forward to it, but I will also invite comments in the chat box from attendees as well at that time. So I'd like to point out that we appreciate the support we've had for an unencumbered educational grant from Pfizer to allow us to do this, as well as from the University of Geneva and also from the World Federation of Public Health Associations. So I'll introduce our speakers one at a time. Professor Lisa Nissen is Director and Taylor Family Chair of the Centre for Business and Economics of Health at the University of Queensland, a pharmacist by background and national and internationally recognised leader in health workforce policy, workforce optimisation, scope of practice reform. Her work focuses on improving access to healthcare through workforce and service redesign, multidisciplinary care models, and evidence-informed policy change. She's driven major research change, including the pharmacist-led immunisation practice across Australia. And so it's with great pleasure that I welcome Professor Lisa Nissen.
So thank you everybody for having me all the way from Australia on your screens this evening. So good morning, good afternoon and good evening, depending where you're coming from across the world. And it's great to share the screens with so many esteemed colleagues from across the world talking about this really important topic. And I get to launch out this evening looking at really setting the scene around the power of using co-administration to optimize the opportunity around vaccination. So really highlighting some of the platforms that we'll build on later with my presenter who's going to follow next, that will focus a little bit more on some case examples and opportunities, particularly in kids vaccinations. But what I wanted to cover with us today is really we're looking at influenza and COVID and some of the things around that space, and why co-administration is something that we're revisiting, even though it seems like something that's quite intuitive, but also around the space of why pharmacy is a good opportunity for vaccine co-administration, given that around, and people will be aware, I guess, through FIP, the International Pharmacy Federation, and local documentation through pharmacy organisations. I think as Michael introduced, countries like Australia in the last decade have introduced pharmacy vaccination, the opportunity of using pharmacy as a platform to add to the public health and prevention space around vaccination for preventable diseases. So I think when we're talking about co-administration, it kind of makes a lot of sense that we're talking about administering multiple vaccinations, so not necessarily just two different vaccinations in a single clinical encounter. And I think what's important to remember is that we probably had a period of time when COVID was around, that we had some uncertainty around the reactions that may occur with the COVID vaccine when it was originally available, and the idea around co-administration of an influenza vaccine and a co-administration then with a COVID vaccine was uncertain. We didn't know what the reactions would be if you put the two together when COVID was a new vaccine. So there was definitely a separation that was recommended, the 14-day separation as an initial policy, because it was a precautionary measure. And that sort of built in, I think, some of the original, well, it definitely did, some concerns around co-administration of the two vaccines. And that becomes sort of an enculturated belief that you have to separate the two because of the initial belief that we were uncertain and concerned that we were uncertain about what would happen if you put some potentially reactive vaccines together, and we didn't know. Now that we know that there's not really a concern about putting the two together, the profiles around the side effects are very similar. They've kind of removed the idea that you need to time them separately, and that co-administration of those two vaccines is actually a good idea given the seasonality of flu and COVID, and co-location of those vaccines is actually a clever idea. So the sequencing of those kind of things, there's a historical thing, an enculturation, and some people haven't really moved on from the idea that you need to separate them. And a lot of patients haven't either. So we're bringing people back into the idea that they need to, or they should be getting COVID still as a prevention. There's COVID still around in many of our countries. But people are like, oh, well, last time I had to have it, I separated the dosing. I couldn't have my COVID and my flu at the same time. So there's some education that we still need to do. The rationale for co-administration seems quite logical to us, but it's not always something that is logical to everybody. The idea that you would increase coverage by being able to catch people for all of the vaccines, or the vaccines that they should be having or could be having, so opportunistic vaccination, or catching people that may not return for a vaccination. If you sort of say, hey, it'd be really good if you could come back and have a, vaccination, but they may not return. So increasing coverage by vaccinating people for the right thing at the right time when you have them with you. And that's part of the avoiding of missed opportunities. So giving people the recommended vaccinations at the time that you have them, and you are having conversations about vaccinations. And I think where pharmacy has a great opportunity, particularly, is the advertising, the public health initiatives in pharmacy saying, ask me about vaccination, and being able to have those conversations about, somebody who is over 65, or somebody that is in an eligible range because of their chronic diseases and other conditions, and saying, well, what actually should you be having? What are the vaccines that are the ones that we should be discussing, not just, because they're coming in for flu and giving them COVID, but what are the other vaccines that they could be or should be considering based on their background. The timing, at the time of peak threats, obviously during the flu season, there's a range of respiratory vaccines that we should be considering, not just influenza, but a range of others, particularly depending on people's comorbidities and other conditions. And it's definitely efficient. It's very cost effective to get people coming for one visit rather than 2 visits, 3 visits, or 4 visits. So I guess this has often been a question that comes up, and people might say this, and parents, we're going to hear maybe about some of the children's programs, is it going to overload me if I have lots of vaccines at the same time? I think what we know is that the experience that we've got is the adverse event profiles are generally similar, whether we give them alone or simultaneously. So we're not overloading people by giving them multiple vaccines. I certainly have some very interesting memories of my children going to the childhood vaccinations and getting four needles simultaneously delivered by 2 nurses into multiple limbs. There's efficiencies in doing that, but also, I don't suspect they were overloaded with vaccine at that time. Common reactions occur and are consistent across co-administered groups of vaccines, and are tolerated and are acceptable. That's an efficient way to have the shared side effect profiles. So it's not meaningfully increasing the risk and severity of adverse events. So that's a good thing, and that's a good thing to be communicating to people too. When we're not doubling the amount of adverse event that you're having by giving you the 2 vaccines at the same time. And we know in ourselves there are multiple co-administered vaccines that exist, and things like DTPA are already co-administered. They just happen to be one in one vaccine. Measles, mumps, rubella is another one that we have that is in one vaccine. So we're already co-administering. They just happen to be one in one needle. So I think that this is, a lot of programs and a lot of protocols already do this co-administration. So it's not as strange as it might look. Some of the actual clinical things that we need to think about, and I think for pharmacists in this space, we often started our vaccination journey in influenza. COVID often expanded this for many pharmacy countries. When COVID came, it expanded, then it moved into DTPA, then it moved into MMR, and then it's moved into a range of other vaccinations over time. We have to be thinking about where we administer it, and without going on a rabbit hole, because Mike's not giving me all of the time in the world, where you put the vaccines becomes important. So the site separation, the distance that you separate it, what kind of separation of limbs, not putting reactive vaccines together and separating them into different sides of the body. So there are principles and processes we need to think about when we're doing that. So there's some clinical things to think about, but there's no doubting that the accessibility of pharmacists and the advantage of pharmacists being based in community as access points to clinical care and access points to prevention is really important. There's a trust in pharmacists and an opportunity for a great dialogue about vaccines that can help to work people through vaccine hesitancy, dispel some of the myths about co-administration, having to space vaccines, and also some of the points around adverse events and cumulative adverse events profiles that people might have in their heads, but things that we know we can help people to understand. And certainly the convenience is something really important. And I just wanted to finish off with 2 slides to give us a bit of a view about why pharmacy is very important. So this is just a little snapshot from Australia, a bit of an advert for Australia that's not about sharks. Some of our experience from Australia, this is some information over the last 5 years about pharmacists' expanding role in immunisation and why these kind of conversations about being able to co-administer, to talk about conversations about other vaccines that might be relevant and important. Pharmacists in Australia now have access to the full national immunisation program range of vaccines. So it's not just influenza, it's all of the other respiratory vaccines that would be relevant for an adult, for example, during this kind of respiratory period where we're really worried about what's getting around. We've got a lot of RSV at the moment. It's really a concern for some of the community. You can see that we're cumulatively increasing the number of vaccines per proportion of the population that are being administered in pharmacy. So this is an increasingly important area of the community for vaccination. So it's important that we are understanding this place and we're understanding our role in increasing this. And so you can see what we are having in Australia at the moment is that vaccination rates generally, which mirrors much of the rest of the world, are suboptimal in our over 65s, but in our broader population. Post-COVID, there's a lot of vaccine hesitancy and uncertainty. We're not reaching the vaccination rates that we want. Our influenza rate, COVID rate, pneumococcal rate and RSV rate are not what they should be. But co-administration vaccines, particularly in this respiratory area at the moment, is a big topic in Australia. It's winter in Australia, not winter like you get in Europe, but winter like we get here. 25 degrees is cold for us. But I think what's really interesting, our data has indicated that even during winter, only about 1 in 4 of our COVID or flu vaccines are co-administered. So even where there is that opportunity with a number of the vaccines, as you could see, happening in general practice and in other settings, as well as pharmacy, only about 1 in 4 are happening as co-administered vaccines. So there's plenty of opportunity. There's a lot of work still to do, but that's a bit of a whistle stop around co-administration. Great public health impact, great prevention impact, and a great opportunity for sites like pharmacy. So I think I haven't gone too much over time, Mike, and thanks for the chance to give that platform for the start of the discussion.
Lisa, thanks very much. And we'll come back to you with a few questions in a little while. And I think particularly from our nurse immuniser, who will also add an extra dimension. I should point out that you do live in Queensland, where that's winter. In Canberra, we do go down to -5 or 6 where I live. So we do understand a real winter as well. It's a big place, Australia, not as big as Africa. And that gives me the opportunity to introduce our next speaker, Jean-Marie Okwo. Jean-Marie is a public health consultant. We're very fortunate to have him because he's a former director of the Vaccines and Immunisation Department at the World Health Organization in Geneva. He's worked for more than 40 years at national and international levels, to support child health, emergency disease control, and immunisation programs. We're particularly lucky to have him here because I know he's been very heavily involved in the Ebola outbreak in Congo. He was director of the WHO Vaccines Immunisation Program, overseeing vaccine research, vaccine regulation, immunisation service deliveries from 2004 to 2017, but he now provides advice right across a range of things as a consultant. Jean-Marie, happy to have you here.
Thank you so much, Michael. And Truly, this is a great way of looking at how, in practice, we can improve the efficiency of immunization program. And Lisa has just made a compelling case that co-administration is technically feasible, operationally practical, and well supported by the evidence, actually. So I will build on that and look at this from a much broader public health and immunization system perspective. Because the co-administration is not a new idea. I started to support immunization program, childhood immunization program back in the early mid 80s. Childhood programs have relied on these principles all these decades. Lisa, we heard you talking about your children, getting several vaccines together. And indeed, when a child comes for vaccination at 6, 10, or 14 weeks, as WHO recommends, for initial vaccinations with pentavalent vaccine together with pneumococcal rotavirus vaccine, all these vaccines are given, as we know, in the same visit. So we do not ask the caregiver to return on 3 separate occasions within the same week for 3 separate vaccines. And in that context, each scheduled contact is used to deliver maximum protection in a single encounter. So childhood immunization schedule worldwide are built around this principle, core one, maximize protection at every health contact. And actually, I remember well, being close to the operational level, in the early days of my career, we had a simple but quite telling indicator on how well the principle of co-administration was applied in practice. When vaccines are scheduled to be given together, the number of persons immunized with each should be the same, and any significant divergence between co-administered vaccine is a warning signal that one has to look at either non-compliance with vaccination policy or logistical failures, such as stock out of vaccines for one of those vaccines. So that's the metric that was used, and obviously today we're focusing on adult vaccination. But before getting that, I would say that we're now seeing an evolution of vaccination platforms. Talked about childhood platforms, but we now seeing increasingly, the establishment of a platform for adolescents, and that's an important one also, because we have to ensure that we have a systematic way of reaching all eligible persons, regardless of age. The adolescent vaccination program still requires strengthening, but it's certainly an important bridge towards the notion of vaccination throughout the life, so the life course approach to vaccination. For adults, we saw the importance of this during COVID, as Lisa nicely mentioned. We know that adults do not follow fixed vaccination calendars. They seek care episodically, and this makes every adult health contact a good way of checking the vaccination status. And I might say on a personal level that yesterday my new GP, checked my vaccination card, and we figured out that I was a couple of years behind my booster for TD, and importantly, he gave me the shot. So that's another point I want to make, that seizing the opportunity of the visit to also provide vaccination required, it requires readiness at the point of care. And that readiness means the health practitioner is briefed. He knows, what is recommended, but he must be equipped, with the necessary vaccines and the related vaccines, the fridge or whatever. Because a motivated practitioner without or with an empty vaccine fridge, will not do much in this context. So why don't I conclude here saying we heard about the evidence, we heard about the efficiency that we get through co-administration. And my main message here would be to say, this is not an exceptional approach, co-administration. It should be understood as part of modernizing adult immunization. So this should become a practical tool to improve uptake, reduce missed opportunities, simplify access, and advance life course vision. And as I started with childhood immunization, I would say that the success of childhood immunization, more than 85% kids vaccinated every year across the world, that success didn't come from vaccines alone. It came from smart delivery strategies, and certainly, the smartest principle embedded in those strategies include the fact that when people come for care, we should protect them as fully as possible during that encounter. Thank you so much.
What a wonderful way to conclude that when people come for care, we should do everything we possibly can to improve their health. And I think that was absolutely brilliant way to conclude. We have two discussants, and Kate Russo is a registered nurse with extensive experience in health promotion and preventive care. Over the years, she's worked in NGOs, public health, primary healthcare settings, but her main focus has been supporting vulnerable communities to achieve the best possible outcome. Since 1998, she's specialised in immunisation and currently serves as the Workforce Health and Immunisation Program Coordinator at the Peninsula Healthcare Group in Victoria. We also have Silvia Gabriella Cinti. Gabriella is a Deputy General Director of the National Institute of Health Service Management in Bucharest, Romania. She has a master's degree in health services management from the London School of Hygiene and Tropical Medicine, a PhD from Karol de Villa University in Bucharest, with extensive knowledge on the Romanian health system, and where she has worked as well as at the WHO and the European Commission for over 30 years. She is also a member of the World Federation of Public Health Associations Task Force on Immunisation Policy, which I have the pleasure of chairing. So I'm going to start with you, Kate, and see how you'd like to react. We've heard a lot about pharmacy, general practice. Did you want to come in a little bit with the role of nurses as well?
Yes, sure. I guess I'm coming mainly from the Australian perspective, where we have a big nurse immuniser program, which has been running for many years. And it's been fairly specific to each state, which can sometimes fragment some of the expectations of the community as well. And as Lisa mentioned, which I'd like to thank both of you, Jean and Lisa, for your great presentations. I think that added another avenue for access to immunisation in Australia, which was very timely when we, came to have a pandemic that required vaccination to pull us out of that. I'm coming from Melbourne, that was the most lockdown city in the world. So we were really grateful for a vaccine that could be provided at different levels. The thing I took out of both of the presentations was the opportunity for opportunistic vaccination. Like pharmacy is set up in a community area, and as Jean said, his GP said, you're overdue, I'll give it to you now. So it's not letting that opportunity go. And the other thing from my nursing perspective is also that it's not just from individual healthcare professionals, but if every healthcare professional talks about it, mentions it, even if it's not the time to be vaccinating or immunising, if it's mentioned, like we find with pregnant women, you'll be able to get your RSV vaccine in a few weeks. And then, then when it comes time, they've already had time to think about it. And maybe have already sourced out questions as well. I think the biggest impact we're finding here is the impact of social media and the messaging that gets out immediately around that. And a lot of the questions that come in around immunisation, sometimes where they've actually got their information from is a little bit grey to that as well. I think Lisa, being a pharmacist in that position of the community, just walking in, and even like John said, with going to the GP, they've got the opportunity to sort of promote those vaccines and say, have you got any questions? Because people don't just turn up to us as nurse immunisers when we're running an immunisation clinic. Often if they want to have a discussion, they're there to be immunised. So then sometimes we are missing those people that aren't wanting to be immunised, or because it's going to take 3 visits because they don't think they should co-administer. So I think this promotion of co-administering, and I think our messaging needs to really be strong with that. I think we made a really good message during COVID, just have your COVID vaccine and then in 2 weeks come back. And so we haven't re-messaged to say, hey, it's okay. The reason we did that was we wanted to make sure if you had a reaction, we knew exactly which vaccine it was. We're introducing a new vaccine. And I think people get nervous and scared, it's new, it mustn't be good, it hasn't been researched enough, whereas we're doing that because we are wanting to ensure everybody's safety as well. And I think that's where sometimes we can let our community down. I'll always have a discussion around immunisation, but it'll always be pro, because that's I believe in it so much. But I want to be able to, have people understand that it is safe, and the co-administration message, I think, really is our way to move forward, moving away from just a single immunisation target for a particular vaccine, but let's give everybody everything. And I think Jean also spoke to it very well as well around, we've got a really good, robust childhood program worldwide. And so the adolescent and adults sometimes do get sort of left behind with that as well. Have I spoken too much, Michael? Unlike me.
Yeah, I'm ready to move on. So, Kate, we'll probably come back to you and give you another chance. But
Thank you.
I'd like to hear reflections from Gabriella as well, and particularly from an administrative but Romanian perspective. Gabriella, on microphone. Yeah.
Sorry. Thank you very much, Michael. And I want to congratulate speakers for the excellent presentations. And I would take forward from the Jean-Marie line that smart delivery strategy are needed, because I think there is no doubt in the scientific world about the patient safety and the public health benefits of vaccine co-administration. But I think we have a challenge of introducing this in practice in the immunization policies and to the vaccination journey and services. And I think a lot of discussions and consultations should be done, because we cannot create a unique methodology, given the fact that the health systems are very different, with many differences in their organization and operation. And also we should take care of cultural diversities and specificities of different regions that can create different attitudes and beliefs in the people. So for this, I think a lot of work should be done in order to create local implementation strategies based on qualitative studies that would understand the barriers and facilitators for vaccine co-administration. Searching a bit the literature, I found the 2014 systematic review of Wallace on provider and parental attitudes toward multiple injection in children. And the results were that the parents and providers were concerned and more concerned with the increase of number of injections, and they were concerned about the pain that the child will experience, about the uncertainty of the vaccine effectiveness and potential side effects. Then that was in 2014. Even more recent studies discovered that there are big size of population that is still concerned about vaccination and co-administration of vaccines. So I think more research is needed on the interventions to overcome the provider and the parental concerns on multiple injections. And also I came across with a more recent study, a GBI scoping review done in 2026. They wanted to see what literature can provide in terms of quality studies on attitudes of population and health workers. So amazingly, they find any study, any qualitative study. They found 9 quantitative studies, but none qualitative study. And this would be more important for understanding these barriers of facilitators. Also, I think we have to look on the other aspects that we can classify as barriers that are on the health system side. For example, Lisa gave us the wonderful example with vaccination and pharmacies. There are different places in which people can get vaccinated, but it could be areas with no pharmacy in the vicinity or other place. So we can organize maybe mobile clinics in which co-administration would be a solution. Also could be financial barriers that are borne by the way the provider, the vaccinator, is paid. Because if he is paid fee for service, he would be tempted to not do co-administration, but to ask patient to come separately for the vaccine. Also, the vaccinator should be the same for the vaccines that are recommended to be done together. And also, I don't know, there are many other aspects of the organization and functioning of the health system that we should take into account when designing such a strategy. So I also do not want to to be too long. I think this would be some ideas of how to put in practice this co-administration of vaccine, which have proved to be safe and to the benefit of public health. Thank you very much.
Thanks, Gabriella. And I'm not surprised you went to the administration issues and how you're going to deal with them. And one of my questions was also about if you make savings, where do those savings belong? Is it with the patient? Is it with the administrator? Is it with the administration? and how do we? But it comes back to that fundamental question that Jean-Marie asked: how do we get the best possible health outcomes? With that in mind, I'm going to go back to Lisa. Let you respond to the other two, should you so wish, but also to think about the issue of hesitancy. Is co-administration likely to increase hesitancy? Because that does affect the fundamental issue about better public health. How do we deal with that? So that's a broad question for everybody, but starting with you, Lisa.
Yeah, no, great, thanks. I did have so many things to talk about on this
Yeah,
panel. It's very
please do.
interesting. Oh no, I won't take up lots of time, but I think the points about technology and the development of technology and opportunities that some of those things bring, I think I'm just reflecting on. And Michael and Kate would be aware, the availability of like flu mist nasal spray in
Yes.
Australia for children. Game changer. Like I have a 12-year-old that we just cannot get a needle into for love or money. Like you'd have to knock him out to get one in. And so being able to do flu mist for flu vax, game changer for us. Where the other one's like, yeah, sure, I'll have a needle. Like he's 14. But that, now we're thinking, what's going to happen when he's going to have his Gardasil and his upcoming vaccines. We're just like, how are we going to manage that? So the route of administration and the flexibility of administration for different communities, different groups of people, the continuation of subcutaneous and intramuscular as a route, the nano patches and, intranasal, that's going to be a game changer for some of this. But then there's, the ability to, double those up and triple those up and, and have multiple, substances in the same one of those for future us. And I think that then it becomes part of that efficiency conversation. So that I'm really interested. The pharmacist in me and is really interested in how we actually make administration of these better, and the biotech people can make it better for us. The second one was, I think, to Gabrielle's point about administration. I think some of the things that we did learn in COVID also, and when I was working in the COVID program with Queensland Health was, place-based administration and working with community groups around like our First Nations community, some of our call community, vaccinating some of our homeless community and some of our displaced refugee communities was not one size fits all for healthcare generally, but because of to your point about hesitancy and mistrust, there's sometimes a mistrust in healthcare, full stop. And, with our First Nations community, there's a great mistrust in the Commonwealth and organisations and a whole pile of different things. If you come in with a team of people all wearing the same uniform who turn up with the truck and they pop up a tent and they're going to, there's a whole lot of connotations with that. So I think, Gabrielle, to your point, it's great to have, places like pharmacists and other health professionals who have the skills and capabilities to administer vaccines. But the greatest success we had with our First Nations program in Queensland was enabling through legislation and regulation our First Nations health workers to be able to administer vaccines. So not only could they have the conversations as trusted members of the community about the healthcare and the risks of the vaccine, which was new, and COVID and all of the conspiracy stuff that was going around at the time, but then they could do the opportunistic stuff because they were trusted members of the community who could then vaccinate. And the people out the back, I was the person out the back making up the vaccine with the immunisation program nurse, and we were handing it out to the First Nations health worker who was doing the administration. So I think it's being much more flexible in thinking about, in many of our countries too, and areas that we work in, about who is the person who's connecting with community. And I think that helps with the hesitancy too, Mike, because I think it's the people that people trust who have the conversations that can help overcome some of those things when there's sometimes a mistrust already with organisational healthcare and organisations. So that would be my comment generally about the hesitancy. Think about who it is that's involved in the care and maybe using those people to help to overcome those things. So that's me over and out.
Yeah, thanks, Lisa. And Jean-Marie, I suppose there's two elements that come out for there. I'd like you also to comment on hesitancy if you feel that more needs to be added, but also I think on training, because it's okay to say we're going to have more people vaccinating. And in fact, I even think of things like oncologists and geriatricians and so on. But what about the training? Because we still have to maintain trust. We still have to prevent hesitancy. What's your thinking across those range of issues and responding to the others as you wish?
Yeah, I think, Michael, in the example of my GP yesterday, I said the fact that I stressed the importance of those practitioners to be briefed, to understand what the requirements are, including, immunization schedules and so on and so forth. So that's a no-brainer. So you're right, training and then follow-up supervision, including using some indicators, as I alluded to, for childhood immunization. All those things has to be put in place, definitely. So you're right there. But you see, we are discussing simply a co-administration, but it's taking us to several components of an immunization program. I don't want to go back to what Kate and Sylvia nicely put out, but and one of the points they made was to bring us to the upstream work. Talking about the need for delivery methods, needle and syringes versus patches and spray and other. Those would make a huge difference. So we are here saying, yes, this discussion should go even in the upstream vaccine manufacturing and presentation discussions, because that will certainly ease some of the fears that we have. Having 3 injections at the same time versus 1, there is a big difference still. Then we have also issues with the implementation strategy. And Gabriel, you talked about, you came back to the point that I made on smart delivery strategy. The way discussion says to what should be the optimal schedule. And I remember from the WHO side, as we were discussing, in the early days, when a malaria vaccine should be administered, for instance, or a new vaccine, RSV, and so we were advising producers, developers, to think about trials that will take these vaccines outside the crowded age range. The 2, 3, 4 months. The early days. So a vaccine can be given, for instance, at 5, 6, 7 months, and so on and so forth. So that we avoid this fear of overloading and so on as much as possible. At the end of the day, it's also being practical and being responsible in relation to some of the points that we have heard, including from parents. Thank you.
Thanks very much. There, I'll go back to you, Kate, to respond to those issues that have been raised.
Thank you, everyone. Great points. I think hesitancies, definitely always been around, and definitely looking at modes of administration are an excellent way to go. And I do think it all comes back to not leading into Sylvia's way with all of the sort of more management side of things, but really getting the basic message out to who you're vaccinating and why it's needed. A lot of our vaccination started in Australia because of our Indigenous community, rotavirus, pneumococcal, because they had the worst outcomes. But we found by vaccinating the whole population, we were more inclined to get everybody on board with that because it was seen as a requirement for all. And I've done a lot of work with refugees and asylum seekers, and at some of the English language schools, we were giving up to 7 vaccines into some students. And they were really accepting of that. Like, it was a lot of needles and they just sat there, but they'd come from areas where they'd seen a lot of the diseases. They believed that this is what they needed. So often it's in that messaging around, like, we've been in these camps, we've seen measles rip through it, we've seen chicken pox, whatever, we haven't had fresh water, so hepatitis is an issue. And we found that and parents would consent to it. COVID vaccine was always the one thing they would say no to. There was that real fear of that vaccine, but we found with the childhood, especially in adolescent, we didn't have an issue. And so it was about having interpreters, people of same cultural background there as well to answer questions. And as Lisa was talking about with Aboriginal and our Indigenous communities, often reaching out to the elders to speak to them about it. You can then talk about how the administration and everything works, but I think it's selling, not that you're selling it because you want to make a profit or anything negative about it, but you really need to ensure that really good basic information as to what it is and why we're doing it and what the positive outcomes are really can make a big difference to people accepting having that many vaccines. Like parents coming, when I've worked in councils, we would give a couple of vaccines. We can offer them flu, and we sort of would say getting the injections all at the one time actually decreases the stress because you've got the stressful moment now, and then they don't need to come back till their next due. So I think a lot of the hesitancy is around communication and ensuring that the correct messages are out there. We're finding a lot of our issues now are coming from big pushes in social media drives and influencers having a lot to say with not necessarily really solid background in what they're saying. And I think coming back to just good communication, listening to your communities as well, like like Lisa was saying with the Indigenous communities, we did a lot of work with COVID with a lot of the Sudanese community here in Australia that were really impacted by the lockdown, and by listening to them we found we had really good uptake with our flu and COVID vaccine during that winter as well.
Yeah, it's interesting with the COVID vaccine, the uptake of the first one when it came out, when all the lockdowns were on. I mean, in my community, 98% of people at that first one said, "Oh, at last," which was absolutely brilliant. But then I think we lost the ability to get the information out that viruses modify, and therefore you do need and you're not actually getting a vaccine for the same virus, you're getting one for a modified one. So these are challenges, but the challenges have been pretty strong in Romania. I know under Ceausescu.
Can I just say one other thing, Michael? Sorry.
Yes, Kate, yeah.
Just also that explaining to the community as well, that we're always assessing and looking at adverse events and looking at the most effectiveness, so that's why things change as well. Like we might change timing or we might change a vaccine, but it's because we keep researching and looking and assessing and going, hey, we don't need that now, or we do need this now. And it's not that it was wrong, it's just that we're learning more. So
yes, it's a good point. And Gabriella, you also touched on administration, but also research and so on. Of course, we have so much research and we have to make our decisions when we can because we want to deliver. And so there's a balance there. You can always ask for more research. What's your reaction, around the issues of trust hesitancy in terms of co-administration?
Well, I don't. First of all, we should see what is the hesitancy to co-administration among the people that accept the vaccination. because those that do not accept the vaccination will not accept also co-administration. And I return to the position that it should be done specifically for specific regions, because we just ended a project in Europe in which we design an intervention to decrease vaccine hesitancy in people over 65 for flu vaccine. And it was implemented in 5 European countries, but a bit differently. So the more successful was in Czech Republic, when the intervention was a movie in which explained the vaccine safety and try to demolish the myths about adverse secondary effects and so on, and then a discussion for clarification. So the most successful was in Czech Republic because it was involved the former prime minister, which was a very familiar figure and accepted by the community. Then it was Romania, because we tried to do this by a general practitioner who invited groups of people to his office. And in Czech Republic, the groups were even bigger because they went to community settings. And less successful was in Portugal, where the administration of the intervention was done by researchers. They didn't trust researchers at all. And even less in Italy, where we put the movie, the intervention was made online. So we discovered that personal interaction and face-to-face is more important than online. And then in France, we couldn't implement the intervention because the ethical committee of Pasteur Institute considered that this is kind of vaccine advertising, and we would harm people over 65 trying to change their attitudes toward vaccination. So that was very weird for us.
Interesting.
Yes.
Yeah.
So you see, there is no uniform method to try people to get on board. So communication is very important, but the way you communicate, it should be done according to the specifics of every community.
Thanks very much. Now, I'm going to draw this to a close. I'm going to give each of you an opportunity for just a very brief comment or takeaway message that you would like to leave. So, starting with you, Lisa, if I can.
I would just say never miss an opportunity. The conversation, the opportunity to talk about vaccines, to hear about what people's thoughts or concerns are, and if you get the chance to stab them with a vaccine, really, just to be very frank.
Well, not necessarily stab. And
well,
you know, we did learn a lot from polio. Way. You know, the polio vaccine being the drops was very easy to administer. So
think about how we give it to them, but I don't think I think it's never miss an opportunity if it's to talk about people's thoughts or concerns, or to talk about how vaccination could be a positive opportunity. And I think that's wearing my pharmacy hat. I think we have so many sliding door moments with patients coming to pharmacies and people coming into pharmacies, and I think, you know, there's times where the door shuts and we miss it, and I think from my point of view we shouldn't miss an opportunity.
Yeah, a great point. To you, Jean-Marie.
Thank you. Very short. First of all, appreciate everyone's contribution. Really learn a lot. And also to say, I wish there is a continuation of this discussion to take the issues, if I may say, from end to end. You know, the research part, as we heard, the implementation part, the hesitancy, whatever, and then the monitoring evaluation. I mean, it's a big range. So we encourage that this continues, so that we can reaffirm how well we do the life course approach. Thank you.
Thanks. To Kate.
Thanks, everyone, and thanks, Michael. Yes, I think I agree with Lisa with opportunistic, taking every opportunity, and as people working in the space in public health, just to promote it, right through to the research, like Gabriella talked about. And I think just really listening to your community when you're planning, whether it's taking into account cultural needs or financial needs, whatever. And I think being open to those discussions as well. Thank you.
Gabriella.
Should I say I'm also very pleased with the discussion, but I think 1 hour was not enough for how much it is to say on this subject. So I think the problem is very complex, and we should look at it from all perspectives, and to collaborate with each other, pharmacists, physicians, nurses, researchers, decision makers, whatever. Otherwise, the good research we have, we cannot put it into practice.
Yeah, look, I think you're absolutely right. And one of the big issues for me always in public health is what I call the public health paradox. The more successful we are, the less people know. People don't see children, as I did, see children with braces on the legs from polio, let alone that died. Hardly anybody has seen measles, and now we're seeing serious measles outbreaks, and so on. And I think this is also a challenge for us. But the issues that you've wrestled with about being opportunistic, about keeping in mind our goal, which is better public health, is really fundamentally what we're on about and how we can do it. And if we can be more efficient about doing it, then that is the most effective way to go about it. So I'd like to once again thank Pfizer for their unencumbered educational grant, for University of Geneva and the World Federation for supporting us, to Dr. Sinti, to Kate Russo, to Lisa Nissen, to Jean-Marie, Okwo Bele. Thank you so much in providing this insight.